Okay. Hello. So I'm sorry we spoke about a lot of things for this session. We're going back to kidney, my patient. We're talking about the HFpEF of the nephrology, which is subclinical acute kidney injury. And we will try to compare the biomarker we can use from plasma or urine for the prognostic of these patients. First of all, as a quick introduction, the definition of acute kidney injury has evolved a lot since the last decade, and Cadigo proposed a new definition based on 3 different entities. The first one is kidney attack. Kidney attack is a situation at risk for the kidney, but you don't have any damage, you don't have any renal loss function. Kidney damage is the HFpEF of the nephrology. We can call it subclinical acute kidney injury. You have a renal damage, but you don't have any renal loss function. I think you all know that you have 2 kidneys, and when you have injuries, you will go below 200% of your normal GFR, but you won't get under this GFR limit. Here, in this context, the use of creatinine, which is a reference biomarker for diagnostic of acute kidney injury, won't increase. So you won't be able to diagnose the damage of the kidney because you don't have any renal loss function. And the last stage, which is acute kidney injury, now we define it with damage which is too much important, so now you're getting under your GFR normal limit, and you will have a renal loss function. In this context, you get an increase of the plasmatic creatinine, and you have renal loss function, we can call it acute kidney injury. The problem is that the use of plasmatic creatinine as an ICU physician, it's too late. The kidney is already in dysfunction. We need to be earlier to assess specific treatment and nephroprotective treatment. That's the reason why, in 2020, at QI Group proposed a new definition based on biomarker for the diagnosis of kidney damage. They introduced subclinical acute kidney injury stage, which is 1S stage. Here, you don't have any increase of plasmatic creatinine, but you have an increase of a biomarker, which we can call it the HFpEF of the nephrologist. The objective of this study is to correlate a little bit with this definition. You know that we don't know any cutoff of the biomarker, which biomarker to use, and what is the difference between all the biomarkers. Using Frog ICU, we have the chance to get 8 different kidney biomarkers at the admission. We will use it to assess the correlation with the prognostic, the mortality, of patients with subclinical acute kidney injury. First result is quite interesting. In blue, it's patient with subclinical acute kidney injury. In green, it's patient with acute kidney injury. So here, there's an increase of plasmatic creatinine. Only 4 biomarkers was quite discriminated for the mortality. NGAL, galectin-3, cystatin C, PENKID, and urinary NGAL were associated with the mortality, and there were no difference between subclinical acute kidney injury and acute kidney injury. So these biomarkers help us to discriminate severe patients without increase of plasmatic creatinine. If we try to go further, we will assess the correlation using different and the number of positive biomarkers. In non-acute kidney injury patients, so no increase of plasmatic creatinine, we have a gradual increase of the mortality with the number of the positive biomarker, and until 2 positive biomarkers, you have an association with the mortality. Which is very interesting is that if you're looking when the plasma creatinine is increased, you don't have this association with the mortality, you don't have this gradual increase of mortality. Probably because plasma creatinine is already increased, so patients have a renal loss function, it's too late. Now let's talk about phenotype. We have 8 different biomarkers. They are not saying the same thing. I think we get, for today's, a lot of talk about biomarkers, and probably they don't have the same pathophysiology. Here, we ask ourselves, what kind of phenotype do they represent? Cystatin C, NGAL, galectin-3 are well correlated to eGFR. They are also well correlated all together. They probably represent a decrease of the eGFR, but they are not associated with the urinary biomarker, which is urinary cystatin C, urinary NGAL, and urinary LFA-BP, and they are not as correlated with eGFR. So here probably we have 2 different groups of biomarkers. One is here to diagnose eGFR loss, and the other is here to diagnose the specific tubular phenotype, for example. Now we ask ourselves, what if we clustered patients using this biomarker? And it's only the beginning of this study. we found 3 different clusters using principal component analysis with a hierarchical clustering. And we found the first cluster, which was patient, non-severe patient, no positive biomarker. Cluster 2, patient with urinary positive biomarker, and they also are non-severe. At the admission, they were more associated with post-surgical complication, neurological complication, and acute respiratory failure. On the other hand, the last cluster, which has plasmatic biomarker positive, urinary biomarker positive, were associated with mortality and sepsis and shock. This is only the beginning, and I conclude this introduction of this project that probably plasma biomarker help us to identify patients with an eGFR loss without an increase of plasma creatinine. On the other hand, we're going to need to go a little bit further. We want to phenotype patients and to know precisely if it's a glomerular, if it's interstitial, if it's tubular, or if it's everything. And that's the reason why we will assess the urinary proteomic to identify specific pathway to probably prevent some damage and assess some nephroprotective treatment. Thank you very much for your attention. I would like to thank all these 3 units that I'm working with. Thank you very much.
Okay, does anybody have a question? Okay, then I'll ask them. It looks to me like you have 8 markers. I don't want 8 markers. It looks to me like any one marker carries about 80% of the weight. And adding a second marker, we get closer, and I don't need any more markers after that.
I understand you don't want 8 biomarkers, but to start and to learn a little bit about the pathophysiology, we need to assess the 8 biomarkers. Probably after, we will only select 1. That's the definition of IQI group. They propose a biomarker, but we don't know which one. There's a lot of literature about kidney biomarkers. We can do another congress about it. But we need to assess specific biomarker for this definition. And after all, probably we can use 8 biomarkers only to classify patients, but it's only for studies, not for clinical pathway.
So a lot of these biomarkers have been on the market, like NGAL, and it died because it doesn't do much. And cystatin C has been used, but mostly for research projects. And one of the biggest problems is creatinine costs about $2, and you're done. And it's a terrible marker, but people are very comfortable with it. So it's been very challenging to make progress in the renal biomarker area, not because they're not valuable, but because they're going up against a cheap, okay marker. Mina, you have a question?
Thank you for your presentation. I'm curious which EGF equation you used.
CKD-EPE.
CKD-EPE.
Yeah.
But actually, CKD-EPE equation was renewed last year, so it will be also interesting to apply a new CKD-EPE equation.
The problem of the new CKD-EPE equation is it could be corrected with cystatin C level. As we are studying cystatin C, it's a confusion process. So we use the old CKD-EPE equation because as we're studying cystatin C, it wouldn't be it would be well correlated with eGFR, but
but all the CKD-EPE equation also have a cystatin C component. It has 3 sub-equations.
Yeah.
So the new equation without cystatin C can be compared with your
we can
eGFR
assess
data.
this without any problem. I guess we just have to change the algorithm. Yeah.
Okay. Anybody else? I think we're good. Thank you.